Story. Next to me is my former colleague here at the Daily Nation, Joy Wanja Muraya, who also went to the Standard but is now a consultant, and she is still a medical journalist within the field and on consultancy basis. Thank you for joining us. Next to her is Dr. Simon Kigondu. I won't tell you what he does on the side when he is not the treasurer of the Kenya Medical Association and, of course, a gynecologist by profession. Next to him is Elizabeth Merab, my colleague here, who's from our health desk, and she is one part of the team that broke this story on the KNH saga, the latest saga that is. There have been many in the last few months. Next to her, and she is a senior science and health reporter at the Daily Nation health desk. Next to her is Seth Panyako. He is the Kenya National Union of Nurses Secretary General, and we're very pleased to have you here because the stakeholders are affected by this particular story, and this is what we want to put on focus right now. So the story that you saw perhaps on your Daily Nation, this is on Friday. This is a story that got many people in shock as, yes, as you can see it there, it was a headlining story. Horror at KNH as doctors open head of the wrong patient. So everyone was asking, what in the world? As you can see there, this was a story done by Elizabeth Merab. Let's start with how we came about, of course, not revealing our sources, but they're credible sources, how we came about this particular story and the treatment of the same.
Thank you, Mark. Well, as a journalist, and every journalist has a team of a list of contacts.
Yes.
So you get tips. Some of the tips may lead to a big story. Some of the tips may not lead to a big story. So for this instance, my colleagues at NTV and I both got tips to this story.
Yes.
And one of the things that I do on a daily basis every time I get a health story, I run it by my sources. I have a team of quite credible sources who I ran a story by, and in this instance they confirmed, all of them confirmed, and that is when I knew it was time to brief my editors about it and see how we can best cover the story without, one, sensationalizing it, and two, losing the readers in the story, because we wanted to highlight the matter without really losing the reader.
And it must have reached the management of KNH that you were prodding and you had some information, because on Thursday they come out with, actually it was on the 22nd, they released a statement to address this particular matter. So were they trying to show that they are addressing this issue before it blew in their faces?
Well, what happened, I had to follow this story for 4 days before we broke it. And for 4 days I was talking to different doctors, consultants, registrars, and doctors working at Kenyatta. And we deliberately decided to see what Kenyatta would do in addressing the issue, because this is a matter that we got hold of, say, 5 days after it happened, 5 days after they had suspended the team of doctors and nurses who had taken part in this operation. And for the 4 days I had the story, nobody from Kenyatta talked about it until I raised the CEO of Kenyatta National Hospital deliberately at 7 p.m. And I think in the moment, in the heat of the moment, they decided to manage the situation the best way they thought of by releasing a statement. Unfortunately, I would say part of the statement did not appeal well to the society, given that a mistake had already happened. But the manner in which the mistake was being managed by the hospital's management was, say, not in the best way possible.
And actually, this is, if my director can get a shot of what I'm looking at, this is what they sent out in terms of a response. Joy, you're a journalist, and I'll get to the medics, the professional medics, to respond to the story and how they received it. Did this, as a journalist, satisfy for you the 5 W's and the 1 H in terms of answering the basic questions that needed to be answered?
Certainly it did, because one of the reasons that why KNH is a top news item is because for a 2,000 bed capacity hospital, And as a referral hospital within our country, it's where we have specialized care. It's where we expect various medical specialists to be attending to Kenyans. However, the nature of this case is not only scary, but also worrying. And this kind of trend in a hospital in particular would cause general fear and would even cause the public to actually stay away from it. But what option do we have as a public with being the only referral hospital within the public health system, faced with a situation where you're sick and you cannot afford a private hospital? Then your best bet is Kenyatta National Hospital.
Right.
The other thing that makes it quite delicate is that we're dealing with lives, human lives here. No, it's not a granary where maize had been stored and and the bags are missing. It's a case where a human being underwent a procedure that they shouldn't have. Yet there are internal systems that should guard against it.
Right.
So I see a case where there was lack of supervision in the entire system, and it's really scary that it had to happen to a facility where we seek healthcare every day.
And let's first talk about the response to this by the management and your opinion on this as the Kenya Medical Association representative for this conversation. It seemed to be, as Merab has mentioned there, managing the situation. Is this standard when there is a mishap in the way operations should be going? Is this how it is handled? Go out in the public and show that there is some action being taken.
Thank you very much, Masai, for this, my invitation. As Kenya Medical Association, indeed, we issued a statement, but we didn't issue a statement on the first day. We actually waited and noticed that actually matters would escalate. And therefore, we issued a statement which was very simple and straightforward. One, KNH acknowledged that an error occurred. That's a good thing. The first step towards correction of anything is acknowledging an error. Secondly, is that unfortunately when anything medical gets into the media, it looks sensational. It's sensational.
In this case, was it?
It is in that an error occurred, and it involves the brain and a wrong operation. That's what was said, and therefore the reaction may tend to make the correction of the problem a bit more difficult. Let's say, for instance, the reaction that some people were suspended. And in our statement, we continued to say that in normal medical actions towards such cases, and medical errors do occur, the first thing that is done is to conduct an audit. Go and find out, and everything is listed from the time the patient came in, to the time the patient went to the ward, to the time the patient went to theater, to the time the patient went back, and to the time the patient went home. An audit is done. In medical terms, sometimes we call it a near miss if the client does not pass away, for instance. But it is also important in medicine because it helps to improve the processes in future. So we asked for an audit, and we said that as Kenya Medical Association, being in our objectives, being two things which are involved in this case, doctors' welfare and health of the nation. See, so as an association being in between there, we can help in the audit because we'll have an eye for both the patient and the doctor. Okay. And recommendations of the audit will then be used to both make improvements, and already in medicine there are systems for such procedures to occur. Okay. It's already defined what needs to be done.
As a representative for the National Union of Nurses, did you have a problem in the terms of how the story broke and how it has been handled? Right now we're talking who should be blamed, or that's at least where the story is heading, because people want to see people take responsibility, action being taken. What's your response to how it broke and how it's been handled?
I think as a trade unionist, and speaking from a person who's very much knowledgeable on HR practices, I believe Kenyatta National Hospital management, the CEO, did what he ought to have done according to the procedure in the human resource. When someone is involved in a procedure that is so fatal like that one, you remove them from practice. You suspend them, or you interdict them, then you investigate, because that is something that's very fatal. So according to me, the hospital management acted within the provision of the human resource practices.
Right.
And also the CS acted within her powers also to suspend the CEO, because this is a systemic problem that must be addressed systematically. We cannot start pinpointing and saying it's the nurse, it's the doctor, it's one. So Kenyatta National Hospital has got very serious systemic problems. When it comes to them giving statements to the public, they have a corporate social responsibility to ensure that the public know what's happening within the hospital, because that's a public institution and there's nothing to hide. So according to me, the media have done their role. I say kudos. I have no problem with that.
Right.
Kenyatta National Hospital as an institution, they did very well to go and respond to the questions that were being raised by the public. But now we as the professionals, we are saying we are not going to accept knee-jerk decisions to a systemic problem. We want a comprehensive overview of what is happening in Kenyatta National Hospital and what is happening in the entire public healthcare system, so that we can cure this problem once and for all.
A systemic problem that needs a holistic approach. Now, let's listen to the KMPDU chair, that is Samuel Oroko, who spoke about the action that's being taken so far and the issue of blame game, their perspective on this.
There are systemic issues that may have led to this issue. We as a union have been very keen on people taking up responsibilities. I've just been addressing the doctors, and I've been very clear to the doctors that we must also do our work. And but part of doing our work.
Forgive us for that mistake. That is Omar Oluga, and he will be talking about the systemic issues that have been brought up by Panyako, and that is at the tail end of this conversation. But on this very issue of the action that is being taken so far and the issue of blame game that is now coming up.
Even if you sack the CEO today, you bring a new one. If the system is the same, mistakes will happen in future. So for me, and us as KMPDU, we don't want to get to the discussion on who takes responsibility. I think it's premature for us to apportion blame to any individual or any cadre at this particular level. What we need to do is a proper medical audit.
But that's where the story is right now. Some people have been sent on compulsory leave and others have been suspended, and there has been reaction to that right now. So it is hard to ignore the story, and we have to tell it. But people are saying we're encouraging this blame game between the different cadres in the medical profession. How do we handle this, Joy, in your perspective? Already people are taking the responsibility.
In terms of handling the situation, at the center of this story is the human interest aspect. So the welfare of the patient is key. It's important to ensure that when something happens, that someone comes out to communicate that this is a situation and this is how we're handling it. The public is less interested in who has been suspended. The public is interested, what are you doing about the gaps that the media has already talked about? Okay. And when you talk about surgery, unfortunately, surgery is just one of the areas that has probably been highlighted happening at Kenyatta National Hospital and probably at other health facilities. So there are times when there are issues and there are errors in the laboratory where you have the wrong samples that are taken, the wrong tests that are done. In fact, in a particular study done in 2017 by Kenneth Kipruto shows that whereas lab tests were ordered by doctors and they went to the labs, in 61% of these cases, there was a missing address in terms of where they should be taken to the physicians. In other aspects, they had a sample that was wrong, so it couldn't be tested. In other cases, they had collected blood that had already clotted and the tests could not be done. So we need to look at beyond surgery. We need to look at beyond the laboratory tests. we need to audit an entire system. And when talking about Kenyatta National Hospital, it starts right from the casualty, which takes as long as 6 hours to admit a patient. So, we had the case of Alex Madago, who, died at an ambulance outside Kenyatta National Hospital, waiting for admission 18 hours later. So we need a radical surgery at Kenyatta National Hospital. The decision to suspend the CEO, I think, is a knee-jerk reaction. We need to overhaul the system from bottom up.
Yeah, the right radical surgery, someone might say, actually, in these circumstances. Merab, we can't ignore this where people are asking, and you actually outlined the process, and the medics will be able to clarify whether it was accurate in terms of who was somewhat to blame in the process and what followed. And labeling seemed to be the issue here. And of course, there has been the person, the ward nurse, the theatre receiving nurse, and anesthetist, as well as a neurosurgeon who have been suspended over this issue. As you told the story, where was the gap? Where was the problem, the biggest problem?
Okay, for me, I'll start by saying that the issue of correctly identifying patients is an issue that continues to result in medical errors that cuts across the board, whether it's giving the right medicine to the right patient, ensuring that the right blood samples of the right patient are given, the results of these samples are given to the right patient, and it trickles down all the way to surgery. In this case, what we saw happen in Kenyatta. Now, as a journalist, I'd say I wasn't out to put names on who is to blame.
Yes.
I like to think that I have a role that is given to me by the society, because the society is just asking doctors to do their jobs and do it well.
Okay.
Yeah? And not only doctors, but healthcare workers across the board, be it nurses, be it lab technicians, be it doctors, be it surgeons, anesthetists, and what have you. Now, if one procedure goes wrong, that is already one procedure too many. You cannot not talk about it. Yeah? And that, for me, was what I was addressing. Highlight these issues, let them be addressed, so that we don't get another case of a medical misdiagnosis, medical negligence happen again, and especially at a referral hospital where the region relies on.
Right.
Yeah.
The biggest, in fact. But this is something that, and it reflects with some of the questions coming up, and perhaps the two gentlemen will help me answer this. Dr. Wandia says, could your panelists in the know tell us what the systemic issues actually are? I didn't quite get it. And a follow-up question, which I'd actually want us to start with, because it follows in the line of questioning I've had here. I also haven't understood how this happened. Was it lab tests, wrong tagging, poor records? What? And the layman Kenyan is asking that question. How could this happen? I'll start with you, Daktari.
This is a medical case. When a medical error occurs, there is a way we audit it. And keyword from this press pass today is an audit. And from an audit comes recommendations. And in an audit, you start from, you sit in a group. Everyone who is involved, who was involved, is actually in that audit. Plus now the external observers and like usually led by the consultant. Yeah? So you do, and it's documented. There are even forms where you document, yes, patient came in, was the label put, who took the pass, what was the handover process, what was the correct issues. And from that audit, issues that may have led to the error are identified. And once they are picked out, then recommendations are made on that. And then these are acted on for improvement, whereby in future to keep minimizing the. There are also manuals, standard procedure manuals that actually show what safe surgery is like. And this has come as a result of previous cases where this has happened. Right. The wrong leg is cut off, or the wrong limb is cut off, the wrong patient. And with the time, because medicine has been there for a long time, then these procedure manuals had been developed. So an audit will actually tell you in this particular case what was the problem.
Given the
I'm privy to the details, but we may discuss it sometime later.
But Panyako, given what has been said and what is out there, what went wrong? People are asking and they would want to know. What went wrong in your view?
Of course, what went wrong is an obvious thing. It's just an issue of patient identification that was not properly done. And we are not going to apportion blame at this point stage because there are many issues that we must look at. That's why we're insisting that these are systemic issues that must be addressed comprehensively and not to have nature. Today is about opening a wrong skull, tomorrow it will be about removing a wrong uterus, tomorrow it will be about something else, removing the right eye and leaving the sick one. So
I mean, you're from the medical fraternity, so this you see almost on a daily basis, but you have to forgive the viewer who's saying, you can't just say it like today it's this, today it's that. Such, you know, somewhat trivial.
What I'm telling you is that this is a serious issue. I have said before that I do not support anything to do with medical negligence. But we are not going also to allow to blame people who have no resources to perform their duties, who have serious human resource issues that must be addressed. My sister said there's only one referral hospital in Kenya. That's not true. There are 4. We have Kenyatta National Hospital, we have Spinal Injury Hospital, and we have Madare Hospital, and Moi Teaching and Referral Hospital. And of important is Moi Teaching and Referral Hospital. It has never had this kind of issues. So we need to sit down and ask, why is it that we have problems in Kenyatta National Hospital? Moi does not have this kind of negative publicity. So then we come to systemic issues. We look at HR and training issues. We look at the issue of infrastructure. We look at the issue of equipment and medicine. We look at the issue of policy and the law. Then lastly, all these things revolve around the financing. How is our public healthcare system properly funded? If it's properly funded, how is these funds being utilized? So that we can come down and identify and say, look, this is where the problem is. And we must resolve these issues. They are, like Moi Teaching at Referral Hospital is a very good example within public sector. When we talk about HR issues, Moi Referral has one of the best management systems and best people in the best places. That's why you see the relationship between the workers and the management is very good. So that when there's an issue, the CEO will even call me, will call the KMBTU, will call KMA, sit down on the table and look at these issues and find out the best way on how it can be tackled so that the hospital can continue to offer the best. And I can tell you for free, give Moi Referral with the kind of management, the next 5 years, it will be the best hospital in Kenya. And in East Africa.
Okay, so break that down for them. Then there is the general. You say medical practitioners in public hospitals do more harm than good through neglect. Zero regard for human life. Bwana Panyako, you should probably respond to that in a bit. Just note it down. This is from, he called himself the general. And someone else here says, Nicholas Ogola, and this is something that our journalists will also be able to respond to. We need to get this right because it seems at least 3 patients were involved in this saga. One whom the family and UON claim to have died, and the other 2 KNH are claiming to be all right. We need explanations. First off, let me just play something that, actually no, let's get some quick responses to this. First of all, Nicholas Ogola, because I feel we'll get lost in responding to many things. How many patients were involved? Today we saw, and we can show some pictures there of UON students protesting earlier today at KNH. And please, if my director would just run the images there. Yes, following some media reports, the students thought that their former comrade Angelos Miano was the one involved in the patient mix-up. Well, in this also, NTV's cameraman John Otanga and KU TV's Frederick Oma were roughed up and arrested and taken to Kilimani police station, and their fault apparently for covering this without permit. Something that is obviously an error on the part of the police officers, who when questioned further said they didn't initially know that they were journalists. Anyway, the 7 UON students are spending the night in the cells after being charged with disorderly conduct. So they were protesting against something they've seen in the reports. Please clarify this. There's this other patient who died and they needed brain surgery, Angelos Miano. If you are privy to this information, would you clarify?
So, a colleague of mine from a different media house, we were just talking, and he mentioned the issue about the dead patient. And of course, I went back to my sources to ask, could it be that one of these patients, the one who actually needed surgery, died? And what my sources, who are doctors, told me is that, well, while one of the patients may have needed surgery to clear the blood clot in his head. He is doing well. Reason being that during the management of a patient, the treatment mode and the management may change depending on how the patient is responding to treatment. So in this case, miraculously, this patient was recuperating well and didn't need the surgery for the, to clear the blood clots. So as much as the wrong patient was operated on, it did not jeopardize the life of the other patient. So then I asked, then who is this patient who died? And I was told that this particular patient was brought in from following an accident along Uhuru Highway, and he needed an ICU bed. We have a big problem at Kenyatta with ICU beds. Madaga died after 18 hours in an ambulance. So unfortunately, this sort of is a repeat case of what Madaga went through, because this patient needed an ICU bed and could not get an ICU bed. And apparently the ICU was supposed to stabilize him as he waited for surgery. And through that, he passed on. Mm-hmm. Now, this patient is totally different from the two patients involved in this surgery mix-up. Okay. That's what I know.
All right, let's respond to the issue of the state of the hospitals. George Brack, you say mediocrity rules this country in every sector, and this echoes what the General says. Medical practitioners in public hospitals do more harm than good through neglect, zero regard for human life. Bwana Panyako, first start by responding to this, people's response to the latest.
I do not agree that public health facilities always do neglect patients. We have very excellent operations and procedures that have been done in these hospitals and has been applauded. You saw Kenyatta National Hospital separating twins. You saw them the other day returning a hand that had been cut off completely. So we cannot say public health system is not working. Personally, I don't have a medical cover. And if I fall down right here, I want you to take me to Kenyatta National Hospital because I can't afford any private hospital. What I'm trying to say, there are systemic problems. One of them is human resource. You are looking at a situation where we have 70 patients in that ward. We had 70 patients, and we have 2 nurses. How do you expect these nurses to give individualized care to these patients when the World Health Organization's recommendation is the highest number of patients that a nurse can take care of is 1 to 6? 1 to 6 means 6 patients for 1 nurse when those patients are not very sick. But when they are very sick, like where you have a patient who wants to go for craniotomy and the rest, the ratio even comes down. Here's a situation where you are handed off patients like sack of maize. We have 70 patients there, 2 are going to theater, you are thrown out the documents. Look at the doctors. They are in theater. They have been operating. Maybe this is the 20th patient. They are operating based on the list. The doctor does not even have time to go back to the ward a few minutes before the operation and actually review the patient. That cannot be a problem of the patient. It's the problem of failure by the government system to put proper human resource in place, equipment. You heard Oroko speak in the KMPD talk about equipment, lack of equipment, lack of things to facilitate health workers to work. You cannot be an equipment yourself. What we have problem like in Kenyatta is to take health workers as a means of protection. So that as long as you are on duty, you have operated on a patient, it doesn't matter. If something goes wrong, they come for you. They don't go for this person who has not ensured that we have enough nurses in that ward, who has ensured that we don't have enough, that we have enough doctors. Why is it our registrars are working without their seniors? Probably those seniors are tired. Mm-hmm. They have been working and they have gone home. So we must address these issues. We cannot continue blaming health workers when the problem is with the government.
Okay, in this response, saying systemic issues, it seems to some that it is trying to absolve the medical practitioners of any blame or taking responsibility because they're under a lot of pressure and the environment isn't the best. To layman Kenyan, Mwananchi who's watching, might be thinking, this was someone with a head injury and someone with a blood clot, and you mix them up. I mean, you go into their cranium, you mix that up. How in the world do you do that? For them, it seems like it's just unimaginable. But how could this happen given the circumstances? They were talking about systemic issues and failures.
This commonly used word nowadays, I think it will become, it will start trending, systemic. And I had Dr. Wandia asking some of the questions. You start with what led to the patient being the wrong patient. What led to the patient being the wrong patient? And I reiterate, an audit has to be done to find out what to do, but we can speculate. Okay. We can say, for instance, first the operation was being done maybe at about 3 a.m. in the morning. From what I've heard from the registrars and some of the doctors there, is that the nurse to patient ratio in the acute ward, in the surgical department, is like you can have 75 patients with 4 nurses. That's a systemic problem. The recommendation is 1-on-1, for instance, if a patient is critical, or 1 to 3 to the maximum. If you go to a private hospital, 1 nurse, 3 patients. So if you have 4 nurses with 75 patients, it's already a problem, can lead to mix-up. 2, labeling a patient. In Europe, I was told, give this particular feedback, the labeling of a patient is a barcode. So that never changes. You go and swipe in a barcode. But if you pen and paper, someone is labeled Kibe or Jude, you see, then you can have mix-up because a lot of Kenyan names are the same, both the first, second, and sometimes the third names. So that can lead to patient misidentification. So in terms of HR, then you are looking at what might have led to the mislabeling. In terms of IT and technology, are you labeling people in a foolproof way such that they cannot be mixed in the, then in terms of HR again, the doctor operating is not the same one admitting. Not necessarily a bad thing if the handover is accurate.
Okay.
Yes. So yes.
All right. Let's talk about something that narrative that's coming out. This is to many people an issue of negligence, Joy, and how we can tell this story without either apportioning blame, but perhaps telling the full process, helping the Kenyan understand the full process. And this was a response by the KMPDU Secretary General Dr. Oluga, who said that it wasn't quite the fault of the neurosurgeon in terms of the blame of negligence. Listen in.
Negligence is either willful or because of lack of expertise, someone doing something that is not intended for the correct diagnosis and or treatment. It's not people mixing up. So if the neurosurgeon did not know how to open the brain, did not know how to look for the blood in the brain, that is negligence. The fact that the neurosurgeon knew how to open the brain, opened up a brain, looked into it and said, look, wait, there is no blood here. That's a competent doctor. So there's no incompetence, there is no negligence. It is just that there was a patient swap. And a patient swap happened because of other complex issues of patient tracking, patient naming, patient tagging, you know. And how comes the bed was switched, the patient was switched. Then when you are in theater, your only guide is the x-ray that you are seeing. Yeah, the patient can't talk to you.
So perhaps are we telling the story wrong, Joy, by tagging it as an issue of negligence?
I want to agree with what Dr. Oluga says. However, what we're looking at in this particular case is the lack of standardized protocol in terms of what is done before, during, and after surgery. And to control this and to ensure that there are minimal surgical errors. In 2008, the World Health Organization set out a process, a 3-step process that should be done in every hospital during a surgical procedure. The first step is called the sign-in, where the team that is operating is supposed to review the patient. This includes identification of their name, including having a second reference on asking them their second name or their date of birth, just to confirm that you have the right patient. It's also a time where the medical team is supposed to confirm whether consent was provided for this particular procedure. In an event where the patient is unconscious, then this can be given, the consent can be given by a guardian or a parent. The second process, known as timeout, is when the entire medical team is inside the theater, and the lead surgeon, makes a call out. Do we have the right patient? Is this the procedure? And then there should be a place where, the mark is made using a permanent marker, so that you're sure that you have the right patient and you will perform the procedure on the right section. So, and it also then ensures that the patient is within the correct position. The third step is known as the sign-out process. And again, the entire team participates in ensuring that after the procedure has been done, then there's sort of like an analysis of you know, what procedure did we perform. You review the operation and probably look at the likely complications. It is also at this step that a count of instrument is done, and everything else that was used, so that you ensure if you have 31 cotton swabs, at the end of the operation you do not have, you know, 28, which means then the 3 that are missing, whether used or not, they could be inside the patient. Right. So this protocol is something that needs to be used each and every time. A study done of 5 hospitals in Kenya, Uganda, Tanzania, Rwanda, and Burundi at the larger hospitals had an investigation just to check how many you know, doctors use this procedure. Interestingly, in Muhimbili Hospital in Tanzania, 65% of the doctors said that they use these checklists to ensure, you know, that there are minimal surgical errors. Kenyatta National Hospital reported 19%. Yeah, Rwanda had 36%. Unfortunately, the doctors in Burundi, you know, and in Uganda at Mulago Hospital say that they do not use these checklists for the reason that they are not available. So whereas this process is not, the public is not privy to this process. As a journalist, what we can do is, you know, get to understand whether this was done as the audit, you know, comes out. And having, as Merab says, at any one time, a credible health journalist will have sources right from the bottom up in a hospital. We will have a patient who is a source, we will have someone in the records, we'll have someone who's a doctor, a nurse. So it's up to us to actually educate the public. Then they get to demand for such things, and especially when the patient is going for referral. Finally, what I would want to say, in what Panyako says in terms of human resources for health, even given the shortage, we have 2 scenarios where you have a shortage of health workers and you have a surgeon in theater who is receiving patients from casualty and they're just being brought in and all they have to do is perform the procedure. We cannot deny that that happens, because it does. Which seems to be the case here. Which seems to be the case, but what is unforgivable is a situation where you have had a doctor who has followed a patient from admission, from diagnosis actually in the clinics, to admission, and then goes to the into theater, and the wrong procedure is done. I think it's important for us to also have that personal relationship for scheduled operations. And this is a process where then would avoid the medical negligence.
Merab, someone might say, when we cite the WHO standards, which are really good and sound ideal, someone might say, ini kizungu mingi, nini ilifanyika? Because there are various versions and narratives out there. And people might say, you know, being skeptics that we are, if we wait for that sanitized report from the audit, it won't be the truth. Perhaps this information wouldn't have come out hadn't they come to the media to bring this out. Then you'll start seeing these versions on social media and spreading out and like wildfire. And there's that version that these 2 patients came in, had the same name. Perhaps they didn't even have minders or guardians to be able to give consent. And this was a complicated issue. What can you confirm from what at least you've had from the credible sources?
Well, without naming names?
Of course.
I had to run the information I had with, to corroborate the information I had with 7 different people, all working at Kenyatta National Hospital. And all of them, interestingly, had the same version of the story. And at some point I was, somebody gave me sort of a statement of what happened. So 2 patients were brought in, 2 men, by Good Samaritans on the 19th of February 2018. I don't know what time they were brought in, but they came in through the accident and emergency, seen by a doctor who recommended, I think they were seen differently, but one patient needed surgery, the one with the blood clot. These two patients were taken to the same ward because this is a ward which houses general surgery patients. And at that point, while the files and all the records were intact, for some interesting reason or weird reason, the name tags were swapped. Yeah. Now, when the patient was wheeled into the theater, he was incoherent. Doctors here, the doctor here and the nurse will tell us if it's true they have a way to measure incoherence, yeah? Because I understand he scored 13 out of 15 or something like that. So he could not really respond to the questions. He was being asked properly. So at that point, I think the doctors decided to manage the situation, to help the patient's health, to restore the patient's health. And in that way, they proceeded with the operation. The ward nurse handed over the documents to the theater nurse. But the ward nurse who was handing over the documents was a night shift nurse, because this operation happened on the 20th at around 11 p.m. So the day nurse who was told by the doctor to take care of this handed over, because at the end of the day when your shift is over, you say, Mark Masai needs a blood transfusion, Joy Wanja needs medication, Kigondu needs surgery. Yeah, and this is what transpired. So at some point, I think 2-3 hours into the operation, the surgeon could not see the blood clot he was supposed to clear. And at that point, he called one of his seniors, a senior registrar, who they consulted, and they came up with the same conclusion that they could not see the blood clot. So what they did next was to call the consultant who was on call. Consultants are always on call for the registrars who are working. So when the consultant drove to the hospital, he also reviewed, and when they could not see the blood clot, of course the surgery would eventually come to an end, and the patient taken back to the ward. But the consultant asked for a second CT scan to ensure that, to know what really happened, because today you have a blood clot, tomorrow you don't have the blood clot. So of course medics would want to know what really happened, and that is why we called it a miraculous, that the patient was recovering miraculously.
Yes.
Now, based on this information, as a journalist and having run it by 7 people,
yes,
I was convinced that I have the right information, that before talking to the hospital's management to get their version of the story, I had the first version of the story. And at this point, the hospital corroborated what I had, yeah. Of course, interestingly, they wanted to know how I got the information. Of course, at the end of the day, you don't reveal your sources.
Yes.
Yeah? The knee-jerk reaction that my colleague, my panelists have been talking about. It's always, who told you? How did you get hold of this information? Because for some reason, it was being stifled. These doctors, nurses, had been sent home. It was 4 or 5 days that we were learning about this. And it's because the registrars now are complaining, why are you victimizing one of our own?
Right.
And you're victimizing him based on the fact that there was misidentification of the patient. It was not something that went wrong in this operating theater.
Right. Cornelia says, what is systemic problem, and why is it that medical practitioners have realized or have come to learn of it now? Is there something that unions are trying to cover? Lastly, what is a penalty for negligence according to union leadership? We're getting to the issue of what we can expect, what Kenyans can expect now that there's an audit going on in terms of the period and the action to be taken. These are things that have happened before but haven't quite been in the public glare, as has been the case right now. So I'll hand it to you first of all, Bwana Panyako. What is this thing that you keep calling systemic problem, and is it that medical practitioners have realized or come to learn about it now?
No, systemic problems are issues that we have addressed over and over many years. You remember, even when we went on strike, KMPD went on strike, they were talking about trying to resolve some of these issues of equipment, issues of human resources. And you remember, that's how the national government came up with the issue of equipment to county governments, two hospitals per county to be equipped. But even after equipping some of those the county hospitals, there were no personnel. So we are talking about issues which go in the core of the foundation of giving proper healthcare services. When you do not have enough nurses, you don't have enough doctors, you don't have other healthcare workers who are supposed to deliver certain services, you can't issue. For example, this particular issue we're talking about, we had actually, I'm told that there were 2 nurses attending 70 patients. What do you expect them to do? You have a doctor who is operating more than 10 hours continuously, operating on a list. What do you expect him to do? So we cannot even talk of, we have a knee-jerk solution to problems which are systemic. We need to address the issue of HR, staff shortage, nursing shortage, doctors shortage, and other health workers, and of course equipment, even medicines, and funding to healthcare system. When Abuja Declaration said 15% should go to health, what are we doing in Kenya? We are doing 2.6%, and we expect quality from that. It can't work. We must also deal with the issue of corruption. Corruption, place like Kenyatta, corruption is too high. So if we don't address these issues, there's no way we are going. And many other issues. That's why we are saying, like today they are saying they have established a task force to look into this particular issue. They have not involved the doctors' union. They have not involved the nurses' union. They are working with Kudeya, Union for Support Staff. What do you come out of that? They have to embrace workers' platform. And workers in Kenyatta can only speak through the doctors' union or the nurses' union. In
your view, then, will this audit be incomplete?
Of course, if you are not involved, we will reject the results. I cannot be part of what I don't know. I am supposed to have a representative on that task force. Not necessarily to participate or give whatever, to observe what they are doing. So that the report that comes out, we can say, yes, we were there, this is what we found out, because they might be going to release a report skewed to please the public at the expense of improving and addressing core issues within the public healthcare system. Patient identification is not only a problem in Kenyatta National Hospital, it's a problem in the 100% of public health facilities in Kenya.
All right. Dr. Simon, first of all, that issue of the audit, what we can expect, but he brings up issues that would concern us in terms of how thorough, how complete this audit you keep quoting, or rather referring to, will be in terms of getting the answers. Yeah. So what can we expect as Kenyans?
And as I said, if there's anything you are to get out of this program today, is that an objective audit must be done. And from that audit, ways of improving how to avoid such errors can become. But over and above that, as I said when we started, the blame game must stop. And part of the
But responsibility must be taken.
Yes, but the responsibility must be taken objectively. And there's an inbuilt mechanism of identifying who's responsible for what. But before you identify what the problem is, you cannot tell someone to take responsibility. Let me give you an example. For instance, the registrars today, they down their tools. Why? Because in their thinking, the registrar did the right thing. And as Dr. Ouma Oluga has said, the doctor did the right thing. He has the pictures. The client in front of the table is the right client, and he operates. You see, but when it comes,
the wrong client, but
it's the wrong client. But that is a retrospective thing. It was identified later, and the surgeon, is the one who identified the client as wrong, because on performing the surgery did not find anything wrong, and therefore questions what it is. But the error was done because the wrong patient was actually there. My take on the blame game. Blame game has to stop because it now the medical personnel become defensive in their treatment of clients when there's a blame game. For instance, just out of the blue, doctors or health workers or nursing staff or any other may, for instance, refuse to receive a client for fear of some unknown punishment in future because that happened, not because something will happen, and that leads to a very, what we call defensive medicine, which is very, when eventually we measure the quality of care to the patient is not good, as opposed to if you treat the patient without funding. And therefore recently the confidential inquiry on maternal mortalities came out. And why it's confidential is because the confidentiality, meaning they remove all the identifiers, makes it objective. And therefore the recommendations of it, and therefore we should allow medics to self-regulate. You see, someone out there hearing the story may jump the conclusion, oh, those doctors are negligent or not.
Another story on
Yes, in self-regulation, I am the one who is in a position as a medical person to know whether there is negligence or not. And then going forward, the media should stop using the word negligence loosely. Negligence is a very precise term and is as a result of an audit. We will only say that you are negligent.
We wouldn't be qualified to label something as negligent.
So negligent is used loosely as you may be surprised that we may actually audit this case and find no one negligent. Yes, there is an error, but we may actually find no one negligent, and that's the point. Okay. So, and when strong words are used like negligence, they attract things like the lawyers start salivating. The lawyers, you see, but negligent is as a result of an investigation. Okay. And therefore, more importantly, what is the quality improvement as a result of this error with systems? And there are many associations that do quality improvement, and that's what we need in our health system. And what Panyako says, more importantly, and maybe I can even go further when we think about this thing, it is the funding in Kenyatta National Hospital. How does the personnel run? What is the relationship with the university? Because when the university withdraws its staff, why does the hospital now the care becomes suboptimal? They need to address that. And I think that is the point where maybe today the funding for KNH should be from the exchequer rather than from the Ministry of Health.
All right, and okay, I'll have to get an answer in terms of what we can expect given the audit that's going on, how long, and when the answers can come in. But as journalists now, will we just wait on that task force to give us the answers, or will we keep digging? For instance, that issue of the state of the health of the patients, the two patients, at least going by what the chair of KMPDU says, Samuel Oroko, he says they are in good condition, and we should be careful on how we handle this story. Let's listen in real quick.
Sometimes, as the media, we need to properly get the true story before we air, because sometimes we get story from the social media which may not be true. Sometimes the patient who died in Kenyatta is not the one who was awaiting surgery, or is not the one who was not left in the ward and the wrong one taken to theater. The two patients, the one who was wrongly operated and the one who was supposed to be operated, are well and recovering well and under conservative management, and they are in good condition. The patient who died is a different case. It's an issue of space in theater.
All right, Merab, you mentioned earlier that they came in without any minders in terms of guardians. They were brought in by Good Samaritans. So in terms of the leads that we have, it's quite limited. But from where you sit, are you able to confirm their state, how they are?
I can tell you for a fact, my leads are not limited.
Okay.
So I can say that the patients are okay. Okay. Because I have seen them.
All right. And that's something that we need to follow and pursue. But the issue of the family, you still have no leads on who their family is.
We will get their family.
Okay. And Joy, to something else that we need to pursue. there's earlier in the year, the issue of the rape, supposed rape of patients, then there's a baby theft. Now there's this. And someone has actually just commented that good discussions, regrettably, the press seems to be capitalizing on KNH mishaps more than helping it to overcome them. So people think there needs to be a balance. This is a hospital that millions go to, but we are always bashing them, or it seems we're really looking for an opportunity to bash them. But our responsibility is to speak of such issues when they come up. Where do we have a balance?
The role of the media is to create and shape public opinion. And if such instances are reported at a health facility like KNH that caters for such a large population, then as our role as the media is to report. What we do as journalists is to present both sides of the story, then leave events to unfold and the public to make a decision. Unfortunately, in health reporting, it is very sensitive when dealing with stories similar to this. If I have a ruptured appendix tomorrow and my only option is KNH, then I might have a second thought about going to Kenyatta National Hospital, given the bad information. But we must report, we will report, we shall report. However, moving on forward, what we can do as journalists is run a sort of a public health education campaign where we tell the public, in as much as these cases are not 100% avoidable, what steps do you take when such thing happens? So do you go to the medical board? Where do you complain? How do you follow up our case? We need a rights-based approach so that then you will know whom to ask and what to ask. Sadly, as he said, and as Dr. Kigondu said, we shouldn't call it medical negligence. They're either medical errors or acts of commission or omission. Our role as a media is not only to highlight Kenyatta National Hospital, but any other health facility, whether private, whether public, so that then we can get to accurately then present as it is. So our role is to present it as it is. But we also will play the midwife role, where in the case where the audit is out, and this is what is reported, if there's a problem with it, if there needs to be an overhaul, then we will report it. But we need assurance and confirmation that when the audit is out, it will be implemented and it will not sit at the shelves. Otherwise, as journalists, we will go digging for those reports.
And from the Health Desk of Nation, and as our closing remarks now, we need to close up. And this is not a witch hunt on KNH. This is just you doing your job. This is not where the story ends. So what next from our Health Desk?
So as you have seen, since we broke the story, we have been on it for the last 4 days. I can assure the public we will be on it until we get the reports and go further to see what really happened and report it as is, airing both sides of the coin. Now, during this process, I received emails and calls, both threatening and both saying that the press is always against Kenyatta. And so I had to mention to people that we were there when baby Satrin's, when doctors removed baby Satrin's bullet from baby Satrin's head. We were there when they separated the conjoined twins. We were there when they reattached the severed hand. But we cannot shut up when it comes to the negative side of the coin. We will report it. I can assure you, as the Health Desk of Nation, we will report it. We will report it, and we will report it fairly. Now, let me read something that a doctor sent me. He told me that every hospital world over is supposed to have a medical errors identification and reporting system. From this, protocols are revised, improved, and patient safety enhanced. If you punish people for reporting or identifying errors, they'll stop reporting them. The eventual sufferer will be the patient, and you never know who the next patient will be. Now, to the doctors, and the nurses, you're doing what the society expects you to do. So not many times will we praise you, because the society expects you to do the right thing. Yeah? But when you do the wrong thing, we will mention it. When you do extraordinary stuff, we will mention it.
Right.
Yeah? It is the society that is asking you to do your job. Do it. There is underfunding, there is understaffing. Yes, we don't deny that. But at the end of the day, as a medic, will you go home and say you've done your job and done it to the best of the Hippocratic oath?
All right. And Bwana Panyako, from the Secretary General's position of the Kenya National Union of Nurses perspective, are you satisfied with how this is being approached? You've mentioned your misgivings about the task force. Are you going to sit there and wait for the report? What action can we expect from you?
We are not going to sit there and wait for the task force report. We are going to do the letter to the minister and say we want to be involved, but we also want a comprehensive audit of public healthcare system in Kenya, so that we have a lasting solution to entire public healthcare system. It's only Kenyatta we're looking at, but Kenyatta does not serve 40 million Kenyans. We have other healthcare facilities in this country that must be audited, and we must put things in place. But we asking for more and open. Kenyatta National Hospital must open up so that workers can have the platform through which they can engage the management, and that platform is only the trade unions.
Right.
If they continue blocking the trade unions, for example, when you block the doctors' union, you don't sign a recognition agreement. You block the nurses' union, you don't sign a recognition agreement. Then you are running the hospital like a personal kiosk. Then you sign a recognition agreement with a domestic workers' union. Honestly, there must be something wrong in your head.
Right.
And you'll expect such kind of errors. And that's why I mentioned Moi Teaching and Referral Hospital. It has a recognition agreement with doctors' union, it has a recognition agreement with the nurses' union, and that's why things are running the way they're supposed to run.
Yes. God forbid a nurse is perhaps said to be responsible, or whether it's negligence, whatever they'll be terming it in the audit, and it is, in your view, objective examination. Will you agree with this?
Of course, we look at the report, and but we want to participate, because the Constitution of Kenya says it should be participatory.
Okay.
Who are the key stakeholders? We have the right to be represented. So because we don't want people to come out with a report, that the board for Kenyatta National Hospital, for example, has been moribund. It literally does not, it only deals with tenders where there is money to get. But when it comes to issues of improvement of service delivery, they know nothing. And that's why we are saying we want to be part and parcel of problem solution, not to be the people to push every day. And when it comes now addressing these issues, we are sidelined. When the problem comes up, it is the nurse, it is the doctor. We are being blamed center, left, right. We want to take the center stage in improving the healthcare system in this country.
All right. From KMA's perspective and position, do you have concerns about the inclusion of all the stakeholders? And then again, really quick, what is your last position, and what can we expect from this task force, the process that we are waiting on?
Kenya Medical Association, in our objectives, we take care of the welfare of the doctors, and we provide for the highest possible health care of the Kenyans and people worldwide. So already from our objectives, we are on both sides in terms of provision of health care. A healthy doctor is equivalent to having a healthy nation, meaning that when the doctor is healthy. Therefore, Kenya Medical Association, and it is touched on in our statement, asks that in this audit, for instance, they get involved, invite the Kenya Medical Association to be an observer. And in that way, the public have confidence and the doctors have confidence, because of, it's the umbrella association for doctors. And this year we are celebrating 50 years in Mombasa, and therefore we welcome you all to our conference.
Okay,
but
it's
that's
not a
our
press
role.
briefing, but yeah,
that's our role. Our role is to make sure that the health of all is protected.
Real quick, what can we expect from this process and the task force and the answers? When can we get them?
Once you do the audit, you will have your answers on why the wrong patient was operated on, and this task force will give recommendations on what needs to be done.
Okay.
But the bigger picture is that the way I look at it is that we should let medics run medicine. When you have people who are non-medics giving guidance, managers trying to run medics, they do not understand medicine. And therefore, some of these problems are as a result of bringing people trying to do medicine when they are not medics. That can be a whole discussion of another day.
Exactly, and part of the campaign that Joy has mentioned we need to carry forward even when the stories are not big, the bigger picture of the management of these institutions.
Yes, we need to restore public confidence, because we can't wake up and you know, go and close Kenyatta National Hospital. It has you know, far-reaching implications. We will not say, you know, now you need to go to Moi Teaching and Referral because it is well managed. There's a reason why it's that referral hospital, including the others that Panyako mentioned. And this should also be a lesson that it's now happening to Kenyatta National Hospital. The county referral hospitals should also learn from this. What is, you know, how are they prepared to deal with medical errors? How will you deal with it? How equipped are you for it? So this is a lesson on what we need to do today. Okay. And also for the public, if you come across a case that you think is a medical error, it's good to actually bring it out and have it ready for investigation.
All right.